I can start. So thank you again for having me. And we now, after this beautiful video, I would like to really acknowledge that the video were very, very nice and beautiful dissection technique. I think that now we have to stop for a second and really think whether the topic of vascular resection and reconstruction in minimally invasive surgery is something that we should treat with cautious, because it is something that is very controversial and still there is a lot of debate on this topic. So I really hope that there will be discussion afterwards, and I really wanted to make a point in order to be extremely clear about what is known already and what is not known. But first of all, one disclosure. I have to say that so far, in my experience, in my hand, this is something that only few surgeons in the world can do. If you're talking about vascular resection with the robot. So this is really something that to date is only in the hand, or better say in the robot, of very selected individuals worldwide. And I'm sure you are pretty familiar with some of them. So this is not a presentation, better say a video presentation on beautiful vascular resection like this one, performed by my friend, Professor Ugo Boggi in Pisa, because I don't think that what we need now is something like this. We need to stop asking ourselves what is the evidence to perform this and what is the direction that we need to follow, so on. We always have to keep in mind that when we treat pancreatic cancer, tumor biology is and will remain king. The selection of patients is very important, so to say, is queen. And all our technical maneuvers, including robotic Whipple, are prince and princesses. Why I'm saying this, I will show you now in the next slides. Starting from the tumor biology, we know that still most of the pancreatic cancer won't be resectable at diagnosis nor after chemotherapy, less than 20% of them. And when we go to surgery, we have a very clear aim, which is achieving a radical resection, which means even with venous or arterial resection, we must acknowledge R0. This is our Bible. These are our rule. So we can talk about robotic vascular resection, yes, but having this very clear in mind. Starting from the NCCN, you all know that we have to classify tumors according to the interface of this tumor with the vessel. And we have a concept of borderline resectability, which is actually more than just a tumor attached to the vein or to the artery. It is every time we are at risk for incomplete resection. So we have to define borderline tumors whenever the risk of incomplete resection is significant. So of course, it's not an anatomical issue, but also a biological one. For example, when the CA 90.9 is high, or you have the radiological suspect of micrometastatic disease in the liver, but also when the patient is at high risk for surgery itself, namely older individuals, or when the performance status is not optimal. Factor number 2, patient selection. How do we select the optimal treatment for our patient? When do we go for upfront surgery? When for neoadjuvant chemotherapy? What is the risk in this regard when we go for upfront resection? Is whenever, even with the most beautiful vascular resection, end-to-end anastomosis, you will see them afterwards, you have early recurrence, complication, positive margin. Not happy. This is very disappointing. I would rather say, yes, we do this extended pancreatectomy, but only after chemo, when the pathological response is good, after adjuvant chemotherapy with negative margin. This is our goal. This is what we aim for as pancreatic surgeons. So how do we evaluate response after chemo? We know that after chemotherapy, radiology is not good to predict resectability. So we have to explore many patients. So again, if we select these cases for the robot, and we know that we don't have unlimited spots for the robot, how can we put all these patients in face of a robotic Whipple? That's a problem. Second factor is the CA 90.9, old but gold. Whenever it goes down or at least stabilize, then we have a candidate for surgery. And this is where the evidence is going. In all borderline pancreatic cancer, there is the indication to perform neoadjuvant chemotherapy rather than immediate surgery. Finally, we go to technical maneuvers, including minimally invasive technique. I define them, prince and princesses. You are all aware of this classification. I am the secretary of the International Study Group of Pancreatic Surgery, and this is, I'm sure you all know, the classification of all the type of vascular resection you can do. I will specifically address now some of them, of this vascular resection, because these are the ones that you can perform minimally invasive or open. This is the easiest one, is a tangential resection. In this way, you don't lose the patency of the vessel, and you do it only when you have a minimal involvement of the vessel. We do it in open fashion. You can do it also with the robot. In the end, you see that it's very nice and easy. You can perform it at the end of the resection. Whenever you have a bigger interface between tumor and the vessel, you might consider doing a patch, which is something that integrates the skills in transplant surgery with that in pancreatic surgery. You see how beautiful it is in the end. You see another example here. You harvest the patch from the peritoneum and then you put it whenever you have a bigger hole. And in this way, you are able to preserve all the vessel here, unlikely in the end-to-end. Splenic vein can be preserved. Inferior mesenteric vein can be preserved. This is a great tool to save all the root of the vein coming into the portal vein. You see here another example of a dual patch. So here we did 2 patch instead of 1. This was a really great technique, which was first described by Safi Dokmaki in France. But whenever the defect is even longer, then of course you have to do end-to-end resection. We do them a lot. It is very easy. And this is, of course, in the toolbox of every pancreatic surgeon. We do it whenever we have an infiltration which is bigger than 15 centimeters. And of course, this you can have it also in the robotic fashion. But also, whenever the defect is even longer, if you have a bank, as the one that we have here in Padova, you can also use a prosthesis, namely a graft, to interplay between the two interface whenever you have a defect which is as long as that. It is, again, quite easy to do with the cadaveric interposition graft, and you can also, of course, do that in the robotic fashion. Once again, it is just a matter of technical difficulty. So the million-dollar question is, are those resections safe and feasible in pancreatic surgery? Many papers. You see how many papers we have only in the last year focusing on the topic. It means it is a very hot topic. So in this case, you see this paper coming from Heidelberg. We define that, of course, whenever you do this type of resection, you have more demanding surgery, more operative time, more blood loss, and also you have more mortality. But it's worth to do because, of course, you have a gain in survival whenever you achieve a radical resection. These data regarding the specific type of anastomosis, and you see, of course, the type 4 are the one associated with the major morbidity. So whenever you can avoid that, it's better. But again, my advice for you expert surgeon is do the technique you feel more comfortable with. As I said, we like a lot type 2 in Padova. Whenever we take a graft, which is absolutely available in the peritoneum, right above the liver, and you can use it to shape it the way you want it. So again, yes, those are standard procedure, but let me underline, only in the open surgery. So right now, the evidence is only regarding open pancreatic surgery and not the robot. But we are now moving to the robotic era. And those are only the 5 studies available, 1, 2, 3, 4, 5, regarding vascular resection in the robotic era. So very few, limited number of patients and series, very selective. What about, first of all, the oncological outcomes? Well, you can, of course, achieve a radical resection. Not surprisingly, you can also harvest a decent amount of lymph node, and those patients are then also able to make it to adjuvant chemotherapy. You see this publication very recently, came from China, and you see that you can safely perform vascular resection even with the robot. Not surprisingly, the robot is not a factor associated with a gain in survival, because it is not, of course, the factor who will make our patient live longer. This is even more important. Is this safe for our patient? And I go back to the concept that I showed you before this morning whenever I talked about learning curve. So if your learning curve has been passed, then yes, you can do robotic PD with vascular resection almost with the same morbidity and mortality than with the open fashion. So that's, of course, a good news. But again, we have to super select where we perform this surgery. This is another paper, again, regarding PD with the robot. You see that whenever you add vascular resection, you have more morbidity in terms of clavio. Not surprisingly, it's the same as in open. And again, after the learning curve, you have outcomes that are similar to the robotic Whipple without a vascular resection. So again, it's a matter of going through your own experience. Finally, is it technically feasible? Once again, it's obvious that whenever you add vascular resection, you will have longer operative time, you will have more demanding procedure, but they are the same, you see here, as for the open fashion. So the factor is adding a vascular resection. If you add a vascular resection, you have longer surgeries, yes, but this can be safe in expert hands. However, keep in mind that whenever you cut vessel, you have more blood loss, and then you have also more morbidity. Same concept as in the open fashion. Keep also in mind that once you are experienced, also the conversion rate is not higher, but remember the same slides I showed you before. You need to perform at least 85 to 90 robotic Whipple before being a master of the procedure. So never attempt a vascular resection if you are not in this part of your learning curve, because this could be, of course, a danger for your surgery. Then, whenever you perform minimally invasive surgery with vascular resection, the outcome are absolutely the same after your learning curve as for the open fashion. So to conclude, you see, for example, in this case, that at the beginning of the learning curve, of course, your operation time will be longer. Then you reach a plateau, at least for 40 patients, and then you start to go down in terms of operative room time. But again, this happens only afterwards. So to conclude, robotic Whipple plus vascular resection can be defined as safe only after more than 100 robotic Whipple. And that's very, very important. Those are the international consensus guidelines released last year. You see that there might be an indication to potentially perform this surgery, but the evidence is low and the recommendation is weak. So we are still talking about a very, very selected handful of not only patients, but only surgeons. So we need more evidence, which will probably come with time. So I conclude where I started. Occasionally, with our robot, with our minimal invasive technique, we try as surgeon to usurp the throne, but we almost fail because we know that the king and queen of biology and patient selection are actually more important. There is nothing as bad as someone who can say, I can do everything because I can technically do it, because even the most skilled surgeon in front of the biology becomes, as you can see here, absolutely clueless. So thank you again very much for having me, and I hope to have some debate with you. Again, thanking you and congratulating Professor Kerem and all the professor of surgery in Baku for the creation of this fantastic chapter of EHPBA from my side and Mark Besseling's side. We very much look forward for future collaboration. Thank you very much.
I'm asking for any additional comments. Yes, Mr.
I have no question. Can you hear me?
Yes, I can hear you, but I cannot see you, unfortunately. I'm sorry. I apologize.
Okay. It was a great speech, as always. And thank you for great contribution to our association and today's meeting. And Professor Nuru had a plaquette prepared for you. If you want, I can get it on behalf.
Please, and I'm sorry if today I'm not in great shape, but unfortunately I don't feel well, so that's that's my problem. But I hope that you get the message that we don't have, and Professor Kerem, who's a great friend of mine, I'm sure agrees with me, the minimal invasive technique just because we can do it. We are surgeons, we treat patients. We want to cure pancreatic cancer. So it is not this the most important factor. If you can do it with the robot, perfect. But always remember the rules of oncology. Always respect the patient to cure pancreatic cancer. I really wanted to make this point. Then I'm sure that in Professor Kerem's hands, in the hands of the great presentation that I saw this morning, everything is possible. But still, we have to remember that we are facing pancreatic cancer. That's the most important issue that we have.
We are waiting for plaquette now. You have any question? Soru katkısı olan var mı? Kadir? Yok. Arkadaşlar?
Yoksa ben sorumluyum.
Thank you very much, Dr. Giovanni, and thank you, Dr. Galli. I have one question to all surgeons who do robotic pancreatoduodenal resection, or in general, robotic surgery. My opinion is that near future, all operation, not only closed, but all open operation also will be done by robotic. What is your opinion about this approach?
Thank you for the very important question. And it seems easy to answer, but it's not. I would agree with you maybe one day, but if you ask me right now, if we will perform all the operation with the robot, this would be not sustainable because of the cost and the cost effectiveness. So we have to think also globally, also on those centers who doesn't have the robot and still they treat patient. So we don't have to say we all must use the robot. We want to, but it's not reality. The most important factor is do your operation the best way you can. It's better to have a good operation without the robot than a bad operation with the robot. You agree? So the future, yes, we need more robot, low cost, more surgeons able to do. But remember that the most important factor is how to treat the cancer in the pancreas. So I don't think that there will be only robot in the future, also because we all need to reach a level where we are master with the robot. This will take years and years. Right now, the most important thing is to do the good operation, no matter with the robot or in the open or laparoscopy, okay? It's easy to learn the robot, easier than laparoscopy. I started from zero and I do now selected cases with the robot. But again, it takes time and still I don't feel that I do everything that I do in open exactly as I do it in the robot. It will happen, but not yet. And I cannot perform all my surgery. We do more than hundreds here in Padova, all of them with the robot. Is impossible. So those are very important factors. Thank you, Professor, for this question. Very important.
Thank you. Now, Mr. Kerem will get plaquette on behalf of you from Mr. Rohde.
Could you see us? Could you see us?
I see. Thank you. Can you bring it to me, Mustafa? So I put it in my room, okay? I have also yours, the Turk HPB. I also have the pin in my room. Huh? Thank you very much. Thank you so much, and congratulations. I'll be waiting for you in Dublin. Thank you so much.